Hi, I'm Lee Kelso, host of the Health Call Live Radio Hour, and I am glad you're here to learn about a surgical procedure that seems to be highly effective in reversing type 2 diabetes, as well as making an overall change in the health of people suffering from morbid obesity. It's called metabolic bariatric surgery, and we're going to learn more about that by welcoming today's guest. He is Dr. Shanu Katari. He is the president of the American Society of Metabolic and Bariatric Surgeons. Thanks for coming on to share what you know.
Thanks, Lee, for the opportunity.
What do you think is the most important thing people need to understand about this procedure? And then we'll get into some of the details.
I would think is first and foremost, it's important to know that we have more than just weight loss is the goal from weight loss surgery now. In fact, we changed our name from the American Society for Bariatric Surgery to American Society for Metabolic and Bariatric Surgery many years ago because we know now the profound impact that this operation has on diabetes as well as other medical conditions as well.
You know, what brought me to you was a report from the European Society for Diabetes Management that said physicians need to be more aggressive in talking with their patients about control of diabetes, including prescription medications and even bariatric surgery for some. So let's go down that path a bit. What is there about this procedure that changes diabetes? Because I understand that you can leave the hospital after surgery and be free of medications for type 2 in some cases.
In many cases, that is in fact the case. And let's take gastric bypass, for example, one of the more common procedures done in the U.S. and been done for over 50 years. The operation itself, other than the fact that we do it through minimally invasive techniques, which have less pain, quicker recovery, and quicker return to work, and less wound-related complications, the essence of the operation hasn't changed in 50 years. Our understanding of what it's doing in the body has completely transformed in the last decade or so. And we understand now that when you do the Roux-en-Y gastric bypass, food does not mix with bile in the duodenum. That's that first part of the intestine right after the stomach, because hence the term gastric bypass. It's partitioned off, and so food doesn't mix with bile in that location. And through mechanisms that we don't fully have elucidated, but a lot of research is going on in that area, that can cause a hormone in the body called GLP-1 to go up. When GLP-1 goes up, it basically tells your pancreas, hey, you need to start making insulin and doing your job. And when that insulin goes up, you don't need to have the shots as much or as many oral hypoglycemic pills, because now your body is starting to do that, which it hasn't been doing in that type 2 diabetes state. So particularly patients with early diabetes, meaning only a few years, who might only be on oral hypoglycemics for the management of their type 2 diabetes, you're absolutely correct that many of them go home off medication in a euglycemic or normal blood glucose state.
So that's a pretty remarkable shift. And it all comes about because of a change in how our body processes or produces hormones. So that's with one specific procedure, the Roux-en-Y, right? That's what you're talking about there. That is not the most commonly used form of of bariatric surgery, though. The other is the sleeve procedure. So does that have the same impact?
Interestingly, it does seem to have a metabolic impact. Again, the mechanisms of which are yet to be fully elucidated, but you're absolutely right that even the sleeve gastrectomy can have a weight loss independent effect on the impact on type 2 diabetes as well.
So while we're there, let's just talk a little bit about what happens during the surgery itself. So is this an open surgery or is this laparoscopy?
No, the vast majority of these are all performed in a minimally invasive fashion, or what we call laparoscopic surgery, which is where a camera is placed near the belly button, and through small incisions using long, slender instruments, the surgeons are able to complete these operations.
And then let's talk first about the sleeve procedure, since it's most widely used. What actually is happening here? What are you doing to my stomach?
Yeah, so we're actually removing a good portion of it. And so a tube is placed down the stomach, and we literally partition or use a stapling device to cut off and remove a portion of the stomach. So 60 to 80% of the stomach is physically removed, but the GI tract is not altered. You still have a stomach. It's kind of shaped like a banana now. And so food now goes from your esophagus into the sleeve portion and then into the duodenum itself. And so another way that operation works is that portion of the stomach that is removed makes a hormone called ghrelin. That's the hunger hormone, that mid-morning thing like says, man, I'm hungry. And so when that area of the stomach is physically removed, it impacts hunger hormones and gives patients a sense of satiety, which also can help in terms of aiding with weight loss after that surgery.
So is that form of surgery, the gastrectomy where you're actually removing part of my stomach, is that as effective in treating diabetes?
It's almost as effective as the gastric bypass. But in general, the gastric bypass seems to have a little more powerful metabolic effect on diabetes than the sleeve. Although some studies have shown equivalence, there are other studies that show that the gastric bypass is probably a little bit more superior in that patient population.
So for the Roux-en-Y gastric bypass, you're actually rerouting the process that food goes through my body, right?
That's correct. In that case, but in a gastric bypass, unlike the sleeve, nothing is physically removed from the body. It is simply partitioned and rearranged. So the stomach is divided and made a small pouch. 9% of the stomach never sees food again. Hence, it's termed the stomach is bypassed or gastric bypass. But in order for you to be able to eat, then you need to have an outlet from that small pouch. So the small intestine downstream is divided. That distal end of the limb is then brought up and sewn to that small pouch. And then the old stomach and that piece of intestine where its digestive juices then come downstream and meet downstream to allow the digestion to occur beginning at that stage.
Okay, so it sounds like I have less small intestine involved in this process. Is that right?
You do, but it really doesn't affect caloric intake. What we call macronutrients. What it's really that impacts is the micronutrients, meaning your absorption of calcium, B12, iron. These are the things that you definitely have to take after surgery lifelong because those are preferentially absorbed in that area that is bypassed. So hence, we need to flood the system a little bit so the rest of the body learns to absorb those in that remaining small intestine. Again, it's not really through caloric restriction or malabsorption as we traditionally thought decades ago that the gastric bypass worked. It's through a more powerful hormonal effect, like we said, rise in GLP-1. The ghrelin is also suppressed because that part of the stomach that often sees food for where that ghrelin is made is bypassed. It's partitioned. It's taken out of that feedback loop. And there's another reason we think that gastric bypass works, even the sleeve as well, because food gets to the distal or downstream part of the small intestine faster. It's not slowly leaving the stomach. And when that triggers another hormone called peptide YY to go to the brain and tell a patient that you're full. And so there's a lot of different mechanisms how we see the powerful metabolic effects of these operations now through hormones that have more recently been discovered that have fundamentally changed our understanding of how these operations now work.
You know, all this is fascinating. So who's a candidate? How is it driven by how overweight I am, or is it more of a function of how severe and out of control my diabetes is?
That's a great question, Lee. And it's actually both, but we need to be moving more towards the latter instead of just using an arbitrary or set number. And so traditional indications for these types of procedures include what we call a body mass index or BMI, which is a calculation of height versus weight. And typical traditional patients have a BMI of what we call 40, which roughly translates into about 100 pounds over one's ideal body weight. You can also be a candidate with a BMI in the 35 to 40 range if you have obesity-related comorbid conditions such as diabetes, high blood pressure, sleep apnea, if you will. Those are sort of our traditional indications, and many insurances honor that. However, we now have over a dozen prospective randomized trials showing metabolic surgery is superior to maximum medical therapy for type 2 diabetes. There's just simply nothing else as powerful a tool in our toolbox than what we have to offer. And so we, as the American Society for Metabolic Bariatric Surgery and others, have begun to endorse patients with a BMI of 30 to 35 with type 2 diabetes need to be strongly considered as an indication for metabolic surgery. And we've had over 45 societies that have endorsed this idea of metabolic surgery for type 2 diabetics with a BMI of 30 to 35.
So, how is life different for me after surgery with my stomach so small? Obviously, I have to change my relationship with food, but what else?
Yes. So uh, it's a multidisciplinary team approach, which includes obviously nutritional counseling prior to surgery, behavioral health intervention, and counseling prior to surgery to get one mentally and physically prepared for these life-altering changes. Because many things can change in one's life and not just one's eating habits. And so we do a lot of pre-op counseling and preparing patients through seminars and one-on-one meetings to prepare for the food choices and what life's going to be like. One of the biggest side effects we worry about after surgery is dehydration. And so, of course, particularly in a COVID era, we want to keep patients out of urgent cares and emergency departments needing fluids. And so a lot of counseling is done around that. And you'll be counseled a lot in terms of what are the choices of foods, but really you want to make wise choices afterwards, particularly in that rapid weight loss phase about protein intake. Protein intake is key during that rapid weight loss phase in that first 6 to 12 months after surgery. That allows your body to to lose the weight from the excess fatty stores rather than from the muscle, because we don't want muscle loss. We want excess fatty tissue loss. And so the protein intake afterwards is key.
And I assume you're going to be counseling me on exercise and many other things as well, right?
Absolutely. And as you begin to lose weight, whatever you're doing as you get in more shape, that won't be exercise for your body. You'll be conditioned for that. That's simply activity. So patients will have to learn to set new goals, new distances, new intensities of their workouts to keep up with their new body. And exercise is not only key, is one of the few things you can do to raise your resting energy expenditure, meaning allow you to burn more calories in a day by increasing muscle mass. It's also really key in terms of keeping that weight off long term. Exercise is the key to weight maintenance after the surgery.
What's the average age for this procedure that you've seen?
Most patients in the U.S. Are about 47 years old, so between 45 and 50 in terms of age. And actually, that's the same in terms of their BMI. Seems to be between 45 and 50. Seems to be the quote unquote average patient seeking out these options. About 80% are female.
And long term, if I make it out to 70, 80 plus, how is my life different at that end of the scale as opposed to shortly after the procedure?
Great question. So not only are there the known benefits from a medical standpoint in terms of just the health benefits of having lost significant and substantial amounts of weight, but the reduction in the obesity-related comorbid conditions, including the diabetes, the high blood pressure, sleep apnea, high cholesterol. This decreases the likelihood of the end organ damage, because that's really what diabetes and high blood pressure is about, is we want to decrease cardiac events. And we now have long-term studies that have clearly shown this in multiple studies, that if you take a group of patients that have metabolic surgery and compare them to a group of the same weight and severity of illness with these other medical conditions that don't have it, the patients that have metabolic surgery live longer. We have long-term 20-year data showing that in multiple studies. Why do they live longer? They have less cardiac events, and believe it or not, they have less cancers. So we have 13 cancers where overweight and obesity is a risk factor for those cancers. And so we actually see less cancers in the population that has metabolic bariatric surgery compared to those who do not.
What about things like food choices? Can I still eat things that I love, or are there some things that are just off the diet?
Typically, the refined sugars are kind of off. We prefer not to go down that road because you can actually get something what we call dumping syndrome. Now, some would call that an adverse event or a side effect of the procedure, but we actually see that as a beneficial effect of the surgery, which is, you don't want to suffer from crampy abdominal pain and nausea. We see that as a beneficial effect, perhaps to the surgeries themselves, if that were to occur. But some patients may be challenged, particularly with the red meats can be a challenge at times. But working with the nutritionist, you can often gauge in terms of, frequency of meals, smaller meals, and working with your nutritionist, getting the protein intake that you need, but making sure we get those iron stores in, whether it's through red meat sources or with the iron supplements. But occasionally, those would be the main things that some patients may challenge with, and certain types of red meats just may not go well compared to others.
Okay, I get that. Sure. What about other medications that might have to change? I mean, if my total stomach volume is smaller, am I going to be less effectively absorbing medications?
Another great question. Some patients are on extended release types of medications, which are a slow release into the body. Those are usually wrapped in a capsule that needs acid to slowly degrade that pill. Well, you don't have much acid left in the sleeve gastrectomy or the gastric bypass. Those acid-producing cells are either bypassed or been physically removed in the case of the sleeve. So we're going to want you to switch from an extended release type of pill to a sort of regular acting pill, if you will. The other point of the surgery, though, is to get you off these pills. I mean, obviously, you're going to be on your nutrient supplements in terms of, we talked about in terms of multivitamins and calcium and B12 and things of that nature. But another reason patients seek these surgeries is to get off of 3 antihypertensive medications, to get off 2 lipid-lowering or cholesterol-lowering drugs, And so during that rapid weight loss phase, we often work closely with their primary care doctor to not only wean off potentially diabetes medications, but high blood pressure medications, cholesterol medications as well. Some patients even see improvements in acid reflux and can maybe get off of those pills as well. So that polypharmacy that a lot of patients take is often reduced by the simple fact that they're getting the powerful metabolic and weight loss effects of this surgery.
So who decides what procedure is best for me? As the patient, I suppose I have the ultimate choice, but I'm not going to tell you which procedure to choose. How do I know what if my surgeon is more comfortable with one, but the other looks better? How does all that play out?
Well, that's probably a topic, Lee, in and of itself. We could spend the next hour talking on it. It's
Okay.
One I'm passionate about, but it ultimately comes down to what's called shared decision making, which is how decisions need to be made towards surgery, in the 21st century, in the sense that it's my job as a surgeon to present the advantages and disadvantages of the various procedures that I offer to the patient, laying out in a fair and balanced way the advantages and disadvantages, the pros and cons of each of these, because no operation is perfect in our field or in any field for that matter. And then looking at where the goals are of the patient, and then matching the patient's goals and desires to the procedure that is best for them. There are some patient populations that it's kind of a coin toss. They kind of would qualify for what we call the 2 most common procedures in the country, the bypass or the sleeve. But there are times where patients might be better served with a bypass, and there's times where patients might be better served with the sleeve based on their medical conditions, their overall health, the previous abdominal surgeries that they may have had, that might want to favor one of these procedures over another. And that's where that quality time spent with your surgeon, sitting down, looking at these options and comparing them to that individual patient is very important.
So if I meet those criteria, if I'm morbidly obese, meet those BMI requirements, I'm having difficulty controlling my type 2 diabetes, if my doctor is not talking to me about this procedure, what do I do?
I would go to our website, asmbs.org. We have a Find a Provider website. You can look by state, where do you live? And you will see all of the members of our particular society that are listed there. So you can see a radius based on mileage where those are. And the other thing to look for is, it's absolutely right, which is we want the patients owning their own health and taking this into their own hands. And that's what we're seeing is the number one referral is self-referral. Patients doing their own homework, studying this, and making this decision for themselves. And so we have a lot of educational information for our patients on that asmbs.org website. But that's a way to find some of those surgeons in your particular state and area. And the other thing to look for is to look at it for an accredited center. We have accreditation standards in metabolic and bariatric surgery. And believe it or not, there's almost 900 accredited centers in the U.S. That go through a very rigorous accreditation and review process, looking to make sure that all of the pieces of the puzzle are in place to provide the safest care for these patients.
All right, we have to leave it there. A lot more questions, but time's gotten away from us, so I appreciate it. That is Dr. Shanu Kothari. He is the president of the American Society of Metabolic and Bariatric Surgery. Thanks, doctor.
Thanks for your time and interest, Lee.